I'm Susan Coe from Children's Hospital of Colorado, and I've been asked today to give you a talk on tailored therapies after epilepsy surgery. I have no disclosures to tell you. Things I'll be discussing today, I'll be defining tailored therapies and how this relates to precision medicine. I'll use a case example from my clinic to try to illustrate some concepts about tailored therapy. I will be discussing anti-seizure medications, in particular repurposing current anti-seizure meds to a specific genetic abnormality or genetic disorder, and I'll use TS, tuberous sclerosis, as an example. I'll also discuss very briefly neurostimulatory therapies, going into what the comparisons between DBS, responsive neurostim, and vagal nerve stimulation, as well as whether we can use 2 or 3 of these devices in a single patient. And specifically, I'll be talking about responsive neurostim and potentially using the long-term EEG data that is being recorded from those electrodes implanted in the brain to see if that can help us tailor resections better in the future. So when I got this topic, I did a Medline search on the terms targeted therapy and epilepsy surgery. I found that there were 575 articles written with these two terms in the past 5 years. It's showing how popular this term is and also how vague this term is. In the past, most therapies were based really on whether someone had a generalized or a partial seizure condition, and it really didn't take into account the individual's genetic makeup or pathways that were involved, or the genetic etiologies, or even the personal susceptibilities that someone might have to certain medications, whether good or bad. It was kind of frustrating. Precision medicine is defined as the right drug or treatment for the right person at the right time. And targeted therapies are basically used for a specific disease subtype. The National Academy of Science basically summed it up as saying true precision medicine is disease modifying, where you modify the genetic makeup of somebody. Semi-precision is considered like targeted to that specific disease. And imprecise is what we're currently at. We are currently not at a point in epilepsy where disease modification is possible, either through medication or through surgery itself. The Human Genome Project found more than 500 genes that were related to epilepsy, but we're still having problems due to the complexity and difficulties in targeting the gene itself to provide precise therapies. In surgery, invasive monitoring defines the epileptogenic zone in individuals, and then we tailor the resection based on this. Neuromodulatory devices such as responsive neurostim can provide longer-term EEG data, which can give us more accurate information on the location of the epileptic zone outside of just stimulation effect alone. So let me try to explain this better with a case example from a patient of mine in clinic. I have a 4-year-old who has tuberous sclerosis, and she developed focal seizures at 4 months of age, described as right arm jerking at the time. She was started on levetiracetam, and then she developed head bobbing at 6 months of age. Mom was a little slow in getting to us. In Colorado, we take care of patients all the way up in Montana, so it does take a little bit of time to see us. We diagnosed her head bobbing as infantile spasms at 8 months of age and started vigabatrin at that time, which initially worked, but unfortunately, her spasms recurred again 2 months later, and so we gave her steroids, which stopped her spasms. However, she continued to have right arm jerking, which is her focal seizures. She's been tried on numerous things. We tried her obviously on vigabatrin and levetiracetam, but we also tried her on clobazam, everolimus, and then Mom went out and got medical marijuana from a dispensary and tried her on CBD as well. She ended up putting a VNS in her at 3 years of age because the family did not want to undergo the surgical risks of a resection. And then her past medical history is consistent with TS, where she has cardiorhabdomyomas, Wolff-Parkinson-White syndrome, and language delay. Her mom has TS. So her evaluations that were done, genetically, her mother had this done as a as a teenager and found that she is positive for TSC1, but the child has not yet gotten tested because of insurance. In terms of her long-term EEG data, her EMU study showed that she had interictally central discharges independently. Her seizure onset came from the left central CZ-C3 electrodes. Her MRI, I don't think I have I'm not sure if I have a pointer. No, I don't. So her MRI shows that she has multiple cortical tumors and subependymal nodules, but the biggest tumor really is in her left posterior frontal lobe, and I'm very sorry, but I can't seem to have a pointer to show you that to you. And her SPECT injection basically shows asymmetrical hyperperfusion of the left basal ganglia, which is suggestive of a left hemisphere onset. So she had, moms got frustrated, which is understandable. The VNS just didn't work, so she decided she would go forward with a surgical evaluation. We implanted her with stereo EEG electrodes over the tubers on the right and on the left, which included the left motor cortex and the left SMA area. Basically, her seizures were coming from the left frontal tuber, which corresponds, when we mapped her, to motor control over her right hand. We had a long discussion with the family. They did not want worsening hemiparesis, and so they opted instead to put a responsive neurostim in her with 2 strips placed over that left motor cortex. Her RNS helped a little bit, but she still is seizing, so the parents are now considering going ahead, moving forward, and doing resection since her hemiparesis is worsening. Would you proceed with a resection in this situation despite the use of VNS and RNS, and what's the evidence to support this? So this is her, I'm not sure you can see, but this is her stereo EEG. There is a seizure coming from the left motor cortex. Just take it on my word. This case illustrates some things that we use in terms of tailoring our anti-seizure meds based on a genetic condition. Looking at what the pathway is, for TS, the TSC1 and TSC2 mutations can cause an overactivation of the mTOR pathway, which is shown here. It leads to uncontrolled cell growth by dysfunction of the tumor-suppressing Hamerton tumorin complex. It's also seen in other conditions, which was discussed earlier, which includes cortical dysplasia, hemimeg, and gangliogliomas. Vigabatrin is a medication that is known to be super sensitive in TS kids to stop spasms. Basically, the main mechanism of action is the irreversible binding of GABA transaminase, leading to increased GABA in the synaptic cleft. In animal models, such as the TSC1 knockout mouse, vigabatrin has been shown to inhibit the mTOR pathway, and this is suspected to be a way how vigabatrin works specifically for our TS patients. Clinical evidence has shown, there's 2 studies here by Chiron and Knepp, that use of vigabatrin and spasms are especially sensitive in kids with TS, but there's still lack of adequately controlled trials. This is there was 2 studies that were done recently, one from Europe, which is the EPISTOP trial, the second one just published, which is the PREVENT trial. This is where vigabatrin is being used preventatively in TS kids to stop spasms. Basically, in the EPISTOP trial, 94 TS infants were checked with monthly EEGs, then started with vigabatrin if there was a seizure, which is the conventional way of doing it, and these kids were compared to those where vigabatrin was started with when an epileptic discharge was seen. And the vigabatrin in these children were continued until 2 years of age. The red box there shows that there's a time to first clinical seizure, which was longer in those who are in the preventative group compared to the conventional treatment, and that the preventative group had a reduced risk of drug-resistant epilepsy and infantile spasms, and possibly also reduced neurodevelopmental delay rates. The PREVENT trial here in the US looked at 56 TS infants, 29 were preventative, 27 were compared, and really they didn't find any differences between the overall epilepsy incidence, drug-resistant epilepsies, side effects, or development at 24 months of age. But they did see that the incidence of spasms in the preventative group was lower. Another medication that is used and what we repurpose sometimes for genetic conditions causing epilepsy is everolimus. This is an mTOR inhibitor. Animal models of mTOR hyperactivity suggest prevention of epileptogenesis with these mTOR inhibitors. And it's been previously noted in mTOR inhibitor trials for subependymal giant cell astrocytoma or angiomyolipomas that those patients also had lower seizure frequency incidentally. And there's been several case series which have shown that everolimus has helped with seizure control in patients with TS. But one of the major trials that was done in 2016 using everolimus for seizure control in TS was the EXIST-3 trial. This was a randomized control trial where they looked at high dose, low dose, and placebo groups. And what they found, just take it on faith with those two errors there, that the seizure reduction rate, response rate was higher with the 40%, with the high dose everolimus that was used, but the side effects and adverse reactions were higher also with the high dose group. There's been two adjunct trials for EXIST-3, and they've shown that the response has long-term effect. There's currently an ongoing TSC STEPS trial where everolimus is being used preventatively, similar to what was used for vigabatrin. So more to come. I know this was discussed in a previous lecture, so I'm just going to be real quick. There are 3 different types of neurostimulation devices out there, FDA approved. There's open loop, which is where there's a set parameter for how often you're giving the current and not relating to what the patient is doing. This is an vagal nerve stimulation and deep brain stimulation. VNS effect is basically thought to be hypothesized to be brainstem mediated. DBS is thought to be felt to work by disrupting the seizure network stimulation to the PEPES circuit. Responsive neurostimulation is a little different. It is closed loop. Again, they are able to record EEG data from the electrodes that are implanted. They can implant 4 electrodes with 2 that are recording. And its effect is thought to be due to interruption of ictal discharges, but it might also have some indirect neuromodulatory effects as well. All of these devices are palliative, usually are placed in patients who have their seizure onset zone in the eloquent cortex, or those who have multifocal onsets or generalized seizures. And all modalities show improved efficacy and long-term time periods. Again, this has been discussed before in a previous lecture. Just take it on faith that we can record EEG data from the electrodes that are placed in the responsive neurostimulation device. In terms of whether we can compare all of these 3 devices, there's not much data, as usual, available. There's really no randomized control trial. We don't know, in fact, what biomarkers can predict the response to neurostimulatory devices, whether to use neurostimulation or not, what modalities need to be used, what stimulation paradigms are best, where to even best place the DBS electrodes. We don't even have much data. We do have it is placed in the anterior thalamus and is FDA approved based on the randomized control trial or the SANTI trial. However, there's other areas of the thalamus which have been suggested to be helpful, such as the centromedian for generalized seizures or the pulvinar for posterior limbic seizures. So in general, the choice of modalities, DBS, VNS, or RNS, really depends on the individual patient based on their seizure type, risk tolerance, and patient preference. But it also depends on the comfort of the center and the physician's preference as well. In terms of generalized seizures, there are 2 things that are available, DBS, but also in our center at Children's Colorado, we do use bilateral thalamic RNS. There is studies that have shown that bilateral thalamic RNS has been helpful for drug-resistant epilepsies, but really, how do you determine what to use? It really kind of depends on the child. Does the child have a thick enough skull for the RNS unit? Is the seizure long enough so that we can actually record the EEG data and have the device go off for RNS compared to DBS? And is there a possibility of using that EEG data later on in future resections? This is a conventional paradigm or decision tree using these devices. Basically, all 3 devices are for pharmacoresistant epilepsy. Currently, the FDA has only approved really VNS for generalized seizures. Focal seizures, it can either be non-localized, and if it's non-localized, then it's usually VNS or DBS. If it's highly localized in a non-eloquent area, then surgery is obviously a better option because that has a better seizure freedom rate compared to eloquent cortex, where RNS is suggested. And if there's more than 2 foci, because there's only 2 electrodes that you can record from in RNS, then VNS or DBS is helpful. Again, there's unlikely to be any head-to-head studies based on all 3 of these devices to compare them to, just because of the ethical concerns. And so therefore, there's only really comparative meta-analysis of the current existing data from current existing studies, which is a problem because there's a heterogeneity in the different seizure types that are being studied and the etiologies being studied. Basically, there are 3, when I looked through the Medline search, I found 3 studies. These are 2 of them, where RNS and DBS is better in terms of seizure reduction compared to VNS. There was a study done in Mayo Clinic, which is listed here, where they did do, it was one center doing a chart review. They do use a type of a stimulation device that's proprietary to them, which is called chronic subthreshold stimulation, where they have a broad coverage of the cortex with up to 16 electrode leads in an open loop system. They found that that was had better seizure reduction rates compared to other devices, but they really also found that cortical stimulation, either by RNS or this chronic subthreshold stimulation device, was more effective than subcortical stimulation. Let's see if this works. Basically, this is what their data is. There's just so that, again, there's a higher median seizure reduction rate with the chronic stimulation that they use, as well as a better responder rate. So what about using 2 or 3 devices concurrently? Are there any adverse effects with that? Looking at the literature, this is a study from Misha Gay Brown and others, which was a chart review from 10 centers. And what they found was that there's no issues with using 2 devices, an RNS and a VNS, together, except there were slightly more stimulation side effects seen in the VNS. And both of those devices had a higher efficacy rate once they've been working for a long period of time. Another study here looked at people with VNS that were implanted with a DBS afterwards. Again, no side effects with both devices going off. Similar response rate was seen with the VNS. If they had a good response rate with VNS, then they seem to have a good response rate with DBS. Another study from Mayo was also done looking at their database, and basically what they found in those patients who had a VNS implanted and then either went through an RNS or a DBS is that, again, there's no problems with the safety between using the devices. The VNS, if those had, for those who had a VNS and then a DBS implanted, those with they tend to have, DBS was tended to be implanted if someone had a really good response to VNS in the past. RNS tended to be implanted in those patients that they were thinking that might undergo resective surgery later on. This is the only case series that I could find looking at RNS and subsequent resection. They looked at 5 patients with basically either having an RNS because they had multi-onset focus after doing their evaluation, or because the focus was in an eloquent cortex. They found that 4 out of the 5, they were able to resect later on using the RNS data that they long-term and tailored that resection a little bit better and had better seizure freedom rates. So it is possible to use the RNS EEG data later on. So in conclusion, there's currently some genetic trials going on using antisense oligonucleotides, which are 18 to 30 base pairs, which are chemically engineered for to treat gain or loss of function of genetic disorders by targeting the mRNA. And these trials are ongoing for Dravet and Angelman's. However, there is still the thought that if someone has a genetic condition with a single epileptogenic zone, which corresponds to a structural abnormality such as in TS, surgery is the best way to go, just because they have better seizure freedom rates. Epilepsy surgery in the future is going to need to consider genetic abnormalities in patients to determine what combinations of therapies are best suited for that individual and to progress further towards the hopeful goal of getting disease modification and better precision medicine. I'd like to thank the organizers for inviting me to talk to you today. I'd like to have a shout out to my two colleagues that let me use their slides, which is Dr. Kristen Park and Jae Hyung Lim. And I'd like to thank my friends at Children's Hospital for their support through these years. Thank you.
One, I want to thank all of our speakers for staying on time, so we actually have time to do a brief discussion session. So I see Dave Clark is standing already to ask the first question.
Yeah, so philosophical question. So if you guys say, you can say forget it or not. So we have seen collaboration between two centers. We saw very nicely how people are getting together and collaborating, but many of the major centers are not inclusive of the collaborations, which causes some threat to validity of some of the data because they have a lot of the patients. And then Susie also showed later that many of the series were very small and they were separate and independent. Philosophically, how do we incentivize persons to collaborate in an academic setting where it states that each center should be the best and each person should be the best?
I think we are so stretched with our time, and everything we do, especially in collaboration, takes time. And it's actually negatively incentivized to collaborate. And the only way that I can think of is basically, like Scott Perry said, it's a love and dedication. So we need to find a junior faculty. That's my way of going about. Junior faculty who's interested in research, and they don't have actually other means to do it except for to become part of the bigger consortium. So it requires a motivated individual who's willing to work on weekends, and support from the institution to allow that. So time, I think, is the most limiting factor. Not so much, funds or things like that. There's never enough time. I have a question about the rescue medication in general, and I don't know if you guys have experienced this. And of course it says, and that's how Diastat was indicated. After 5 minutes, come on, right? You're gonna watch a child have convulsive seizures for 5 minutes before you give any rescue medicine? It's ridiculous, right? But parents actually, when you say it, and the nurses say it, and it's written on the action plan, they actually wait 5 minutes before they give anything, intranasal, rectal. So I basically say, at the very onset, as soon as possible, when you think the child is having seizures. And we already know the longer you wait, less effective. The benzodiazepine go into hiding. It's not going to work anymore. So why are we saying 5 minutes? And especially for generalized tonic-clonic seizures, not only if you wait, it will not work, but it is already repetitive. So I think you can justify the FDA indication. For clusters of repetitive seizures, you give diazepam or Versed. So, yeah.
That's a good question. I would say that over time, my practice has changed, that I used to be pretty strict about the 5 minutes. That's just how I was trained. And so I didn't really think about it, but you're right. It is a really weird thing to ask parents to watch their child seize for 5 minutes. And I tell families that very upfront. I say, I know this sounds crazy, but the reason we do this is that seizures will, the majority of seizures will end in less than 1 to 3 minutes. What I've started to do in more years of practice is that I try to get a sense of what that child's baseline is. So if they do have a tendency to go into status, very much so, we're moving that timeline up, right? 2 minutes, 3 minutes, whatever. For most kids now, I just say, get the medicine ready at 3 minutes. I know that probably a lot of parents give it at 3 minutes, and that's okay. And I tell families that's okay. The sense of time is going to be highly warped by the fact that you're watching your child have a seizure, right? And so 5 minutes is more, in my opinion, an approximation, knowing that you're not going to give it right away. You want to observe some time, stabilize the patient, get the medication ready. And so somewhere in that 3 to 5 minute window is typically when I kind of expect parents to give it. Maybe even some people give it earlier than that. I don't know. What do others think?
I just want to take a brief pause, and we can continue the questions in just a moment, but we have one time-sensitive announcement that Dr. Clark needs to make.
Yeah, when we planned this, we didn't think they were going to be running a race this morning. So Dr. Boop has to leave to get to the airport in a timely fashion. But I'd just like to thank him for coming, if you don't mind coming up, Rick, and for being our inaugural keynote speaker for IMPRES. We'd like to give him this back. How are you guys?
Thank you. Listen, this is such a special weekend for me because I've gotten to see so many people I worked with for years and met new people, and I'll remember this forever. Thank you.
All right, we do have time still for a few more questions.
Just as a follow-up on rescue medication discussion, we did run into problems with giving instructions to repeat the rescue medication after 5 or 10 minutes, because we had a school nurse who read the small print for Valtoco, and it says that you're not supposed to give more than 2 in 5 days. So they were very opposed to actually giving more than 2. They felt that it was huge liability on their part. So any comments or thoughts on that?
So I could see a scenario where somebody might need it more than 2 in 5 days for our refractory patients, and I could see how that would pose a problem. But I would probably, I think part of my view of seizure safety is also a bit skewed by the fact that I do a lot of work with PNES patients as well. So I spend a lot of time on the phone with school nurses, and I also have done some kind of outreach with school nurses. So I think talking directly to them and explaining like what the clinical indication is, yes, that's the FDA label, but I mean, how many things in pediatrics do we not follow the FDA label to the letter, right? Like it's impossible. And so, and most of the time that you're using this medicine, you're not going to be exceeding that many doses in 5 days. Just like most of the time you give a triptan, you're not going to exceed the number of doses per month for headaches, right? But we still sometimes do it. And so it's not a reason not to do it. And so I try to meet them where they're at and say that I understand your concern, but this patient needs this medicine, and there are going to be times they might need it twice in 1 week, or 3 times in 1 week. Not very likely, hopefully not, but it could happen. And I don't know that I would feel comfortable denying that kid that medication if I was the school nurse.
So just to follow up on the question, when to give the rescue medication, I like your comment of tailoring according to the patient, but we have to keep in mind that where the 3 and 5 minute came from was a study from Rochester, where they looked at thousands of people over a period of 10, 20 years, and they saw that almost 80-90%, it was an adult study, but almost 80 to 90% of the seizures would stop within 3 minutes. 5 minutes, the longer they would go, the more likely that it would not stop before half an hour. So that's where the recommendation came for 3 minutes, that I think if it's not stopping in 3 minutes, it will become less likely that it will stop anytime soon. So you have to be careful. I think patient-tailored approach is better than just giving it at the kind of beginning of the seizure kind of a concept.
This question is for Dr. Arredondo. Regarding your case about the young NICU patient with the hemispheric abnormality, did you all consider, with the possibility of somatic mosaicism, did you consider sending genetics on the post-surgical sample? And similarly, do you think it would be worthwhile to standardize sending genetic testing on post-surgical samples?
Thank you for that excellent question. Yes, we did consider it and would have loved to have gotten somatic genetic testing on this patient's sample. We are hopefully working on a better way to have a pipeline to be able to do that, and perhaps send samples to some of our collaborative institutions that may be able to help do this as a more standard of care in patients similar to this, where we don't have a definitive etiology. I think that would have been very high yield for this patient in trying to figure out the origin. So thank you for that question.
By the way, there's flash frozen tissue on that patient if you ever want it. We actually send everything to pathology, and we have sort of a unique situation in that whatever they don't use for diagnostics, they usually take a sizable amount and flash freeze it, because we started that protocol with our tumors as the world of genetic testing and tumors changed. So oftentimes there is stuff still in the freezer, at least at Dell Children's.
I think one can almost assume that it is somatic mutation when you actually have hemispheric lesion like that. And I think you would probably don't want to be so aggressive in your whole genome sequencing in this case.
No, I think you're right. It's like there's definitely something somatic going on in this case. Thank you.
I had one comment before I let Dave, and it was about collaboration. And I think that one of the things that we have done very well with the neurology team at Dell Children's and our partners throughout Texas that I did not see in other places that I have been, and that is when we collaborate with neurologists from other places, we do not steal those patients.
Why not?
And we have
a true Emory person.
I came from someplace where we stole patients. And I think that has allowed us to build much better collaborations with the centers around us. And I think that that is an incredibly important but sometimes very challenging component of doing these collaborations across institutions.
Hey, I was going to ask the same thing. And I was actually going to, from your vantage point, Dr. Diet, how do we best do that across centers? Because that's the debate at the AES. The top-down debate at the AES always is PCPs don't send us people. Neurologists don't send us people. But we usually don't ask the neurologists why they don't send us people. And we don't ask the PCPs or nurse practitioners why they don't send us people. So I think after asking this for like 30, 40, 50 years, we're going to have to switch that around a bit and go, how could we best work with you? Not how could we tell you to send us the patient.
I completely agree with you, Dave, and Dr. Talakabara. We tried to do this collaboration, you and I, probably 4 or 5 years ago, with higher level in our administrations. And for some reasons or another, probably competition between institutes, that was not deemed to be successful. But at the end of the day, I think it's no ego in medicine, and we all care about the benefit and the interest of our patients. I know I have a good friend at Dell. I have friends probably at Cook and Dallas Children's. It all depends on where honestly where my patient is, and at the end of the day, where their insurance will allow them to go. So it's, at the end of the day, it's our collaboration between each others is what drives us all to the best of the interest for the patients, regardless of any administrative policies and what have you.